Welcome to the deep dive. If you're here to take a stack of pretty comprehensive revision notes on a specific clinical topic today, it's breech presentation. And, well, turn it into a high-yield, easy-to-digest overview just for you, then you are definitely in the right place.
Exactly. Think of this as your shortcut to getting the key info locked in.
Our mission today is just that, to sift through these detailed notes on breech presentation, pull out the absolute core stuff, the must-know facts, and lay them out so they're easy to follow and, hopefully, memorable.
Yeah, we're not just reading notes back at you. We're trying to build a clear picture based purely on the source material you've given us.
Absolutely. And the focus is strictly breech presentation. It's a big topic in obstetrics because, well, it's different from the usual head-first arrival. It means the baby's bottom or feet are set to come out first.
And why it needs attention, as these notes make clear right away, is because it's linked with higher risks for the baby compared to a head-first delivery. Yep. Things like congenital malformations, problems linked to being born early, potential trauma during the birth itself, and a bigger risk of oxygen deprivation, asphyxia risk during labor.
Okay, right. So let's unpack that definition a little. At its most basic level, what is breech presentation?
So it's defined by the baby being in a longitudinal lie, but with the pedalic pole that's basically the bottom or feet presenting down towards the maternal pelvis.
Okay.
Essentially, it's the opposite of the usual cephalic or vertex presentation where the head comes first.
And the notes mention different ways this can actually look, distinct types.
Yes, that's a really key distinction. The notes describe three main types. The most common one, according to this material, is frank breech.
Frank breech, okay.
That's where the baby's bottom is presenting, but their legs are extended straight up towards their head, hips flexed, knees extended.
Right, like a little body sort of folded in half at the hips. Got it.
Yeah.
What's the next type?
That would be complete breech. So in this case, the bottom is presenting again, but the baby's legs are flexed at both the hips and the knees. Often the feet are kind of tucked near the buttocks.
Okay. So more curled up compared to the frank type. And the third?
The third is footling breech, and that's pretty much what it sounds like. One or both of the baby's feet are presenting first, so they're below the level of the buttocks.
Okay, so frank, complete, and footling. Makes sense. And just circling back, the notes really hammer home that significance point, don't they?
Yeah.
Higher perinatal mortality and morbidity?
They do, yeah. And they link it directly to shifts in how things are managed clinically. The notes mention a trend, especially in Europe and the US, towards using cesarean sections more often for term breech babies.
Right.
And they state that alongside this increase in C-sections, there's actually been a drop in intrapartum and neonatal deaths specifically linked to breech presentation.
Well, that cause and effect is quite striking. But the notes also say there's still kind of an ongoing debate, even with better stats, about elective vaginal breech delivery.
Yeah, it's interesting, isn't it? The data shows better outcomes with C-sections, but the clinical discussion about vaginal breech birth still persists. It acknowledges things like the skill needed, patient choice. The notes seem to hint at that complexity.
Right. So how common is this, actually? Let's talk epidemiology. The notes give us some UK figures.
They do. They state the UK incidence is about 3–4% of term pregnancies. So pregnancies that reach full term.
3 to 4% at term. That feels relatively low overall.
It is low at term, yeah. But the notes make a really important point about how much this changes earlier on. Around 28 weeks gestation, something like 20% of fetuses are actually in a breech presentation.
Wow, 20%. That's a massive difference compared to term.
It is. Dropping from 20% at 28 weeks to just 3–4% at term really highlights a key fact from this material.
Which is?
That the vast majority of babies who are breech earlier in pregnancy will actually turn spontaneously. They flip into the head-first position by about 36 weeks. Nature kind of sorts most of them out.
Okay, so for the ones that don't turn, why does it happen? What do the notes tell us about the etiology, the causes, and the pathophysiology?
Well, the notes are pretty upfront that the exact cause often isn't known. It's idiopathic a lot of the time.
Yeah.
However, they do list several factors that are known to significantly increase the likelihood of a breech presentation occurring or persisting.
And what sort of factors are those?
Things like premature birth itself, having multiple pregnancies like twins or triplets, abnormalities in the shape of the uterus, issues with the placenta like placenta previa, or if the baby has certain fetal abnormalities.
Okay, so things that might affect the space available or maybe the baby's ability or even drive to turn head down. Makes sense.
Exactly. Now, when it comes to the pathophysiology, the sort of how it actually happens biologically, the notes are quite direct in saying it's not fully understood.
So we know factors that make it more likely, but the underlying mechanism isn't completely clear.
That's basically it, yeah. They mention some possible contributing factors that are still being looked into, like maybe inadequate uterine space for turning, certain fetal anomalies affecting movement, or abnormal fetal movement patterns. But these are framed more as areas of research than definitive causes.
Understood. So the why isn't always clear, but we do have a list of who and what situations make it more probable. These are the risk factors. And the notes organize these quite helpfully.
They do, yeah. They split them into maternal factors and fetal factors, which I think is a really useful way to remember them for revision.
Okay, let's break down the maternal factors first. What's
Yeah.
on that list from the source?
Okay, so under maternal factors, the notes list: a lax uterus, which you often see in women who've had many previous babies, high parity; structural uterine anomalies, or things like fibroids; placenta previa, where the placenta covers the cervix; an abnormal pelvic brim shape; and maybe less obviously, maternal smoking and maternal diabetes.
Hmm. Smoking and diabetes being listed there definitely stands out as something to flag from these notes.
It does, yeah. It suggests that wider systemic factors in the mother can potentially influence how the baby ends up positioned.
Okay. And on the fetal side, what factors related to the baby increase the risk?
So key fetal factors mentioned are fetal malformation hydrocephalus is given as a specific example, multiple pregnancy, like twins, having abnormal amounts of amniotic fluid, either too much, Polyhydramnios, or too little, oligohydramnios; low birth weight, which could be from prematurity or growth restriction in the womb, IUGR; and having had a previous breech delivery in an earlier pregnancy.
Right, that's a pretty comprehensive list. And splitting it, maternal fetal does feel like a good memory aid.
Absolutely. And identifying these risk factors is obviously part of the clinical assessment.
So moving on to that, how would a clinician actually detect a breech presentation? During pregnancy or maybe even in labor? What are the clinical features described in these notes?
Well, the classic findings described are feeling a hard, round mass, which is the baby's head high up in the top of the uterus near the ribs.
Okay, up top.
And conversely, feeling a softer, sort of less defined, maybe irregular mass down in the pelvis where you'd normally expect to feel the head. And also, the head isn't engaged. It's not deep down in the pelvis.
And might the mother notice anything herself? Any specific feelings?
The notes mention she might report feeling irregular fetal movements, perhaps different from previous pregnancies or earlier in the current one.
Okay. And are there more specific signs on examination, especially later on, say after 32, 35 weeks?
Yes. The notes give almost a checklist for later pregnancy signs, things like feeling subcostal tenderness, so tenderness under the ribs where the head might be, being able to ballot to the head in the fundal area.
A wallet.
Yeah, like gently pushing the head and feeling it bounce back up high in the uterus. It confirms it's not fixed in the pelvis.
Oh, okay.
Also confirming that softer, irregular mass is felt down in the pelvis, and often finding the fetal heartbeat is loudest above the umbilicus rather than lower down as you typically find in a head-first presentation.
So clues from feeling the abdomen and listening. What if labor has started and a vaginal examination, a VE, is done?
The notes specify that on a VE during labor, you might actually feel the baby's sacrum, their bottom bone, or maybe the anus, or even potentially a foot presenting through the cervix.
Oh, okay, wow. So combining the tummy exam findings with potential VE findings gives a pretty clear picture. How is it definitively confirmed, though?
The notes are really clear on this. The diagnosis is confirmed by ultrasound.
Right. Physical exam raises suspicion, but the scan gives the final answer.
Exactly. And the ultrasound is really useful because it can also check for any underlying fetal or uterine abnormalities, things that might have actually caused the breech presentation in the first place.
That's a crucial double check. And there's a specific point in the notes about referral if breech is suspected later on.
Yes, a really important point for planning management. The notes state that if you suspect a breech presentation that's still there at 35, 36 weeks, it needs a scan to confirm the position, and then a specialist obstetric opinion to discuss the options going forward.
So that 35, 36 week mark is key timing for potential intervention, like ECV.
Precisely. Suspect it, scan to confirm, and if it's still breech, then it's time for that specialist chat, a clear pathway.
Which brings up a good point. What else could these signs potentially point to? Are there differential diagnoses mentioned?
Good question. The notes touch on this briefly. The main things you'd want to differentiate a breech presentation from are other non-longitudinal lies, specifically A transverse lie, where the baby is lying sideways across the uterus,
Okay.
or an oblique lie, where they're sort of diagonal. Basically, any position that isn't head down or bottom down along a main axis of the uterus.
Right, so ruling out sideways or diagonal lies.
And the notes also add that you need to distinguish between the different types of breech presentation, frank, complete, or footling, because that distinction can actually influence management decisions, particularly around the possibility or safety of attempting a vaginal delivery.
Okay. So it's not just, is it breech, but also what kind of breech is it?
Yeah.
Important detail. Okay, so we've defined it, covered how common it is, why it might happen, who's more likely, how you spot it, how you confirm it, and what else it could be. Now, the really action-oriented part, management. What are the options? What's the approach based on these notes?
Right. So the overall approach described here involves sort of three main pathways if the breech presentation persists towards term. You can try external cephalic vision, or ECV, to turn the baby before labor.
Okay.
You can plan for a vaginal breech birth, or you can plan for a cesarean section. And the choice between those really depends on a whole bunch of factors assessed by the clinical team and discussed with the mother.
Let's start with trying to get the baby to turn before labor kicks off. ECV. Tell us about the right.
Okay. External cephalic version. The notes describe this basically as the clinician applying pressure carefully on the outside of the mother's abdomen to try and gently lift the baby's bottom out of the pelvis and encourage the head to rotate downwards into the correct head-first position.
And is this generally recommended?
According to these notes, yes. The RCOG, that's the Royal College of Obstetricians and Gynecologists, recommends offering ECV for uncomplicated breech pregnancies at term, as long as there are no specific reasons not to, no contraindications.
What are the chances it actually works? Does it often succeed?
Well, the notes give a success rate range of 30 to 80%.
Wow, that's quite a wide range, 30 to 80.
It is, isn't it? It really highlights that it's definitely not guaranteed. And the success seems to be influenced by factors we mentioned earlier, like whether the mother has had previous babies, parity, the tone of her uterus, how low the baby's bottom is sitting in the pelvis, the fetal station.
So variable success, but often worth trying if the situation is right. What about safety? Is it risky?
The notes emphasize that ECV is generally considered safe, and specifically, it's not associated with an increased risk of intrauterine death. That's an important reassurance.
Okay. But presumably there can be rare complications.
Yes, they do list some uncommon complications. These could include things like placental abruption, which is the placenta coming away from the uterine wall, uterine rupture, though that's very rare, and feto-maternal hemorrhage, where some fetal blood enters the mother's circulation.
Right.
However, the notes also point out that actual contraindications to even trying ECV are infrequent. They occur in only about 4% of breech pregnancies.
Okay. So ECV is often the first thing to consider if appropriate. But if ECV doesn't work or isn't suitable, then you reach that really crucial decision point about the mode of delivery itself.
Exactly. This is the key fork in the road if the baby remains breech. Planned vaginal delivery versus planned cesarean section.
And what does the NICE guidance referenced in the notes suggest about how this discussion should happen with patients?
The notes state that NICE guidance recommends discussing both options, planned vaginal birth and planned C-section, thoroughly with the patient. They also reiterate offering ECV first, unless there's a reason not to, and doing a final ultrasound scan just before a planned C-section to double-check the baby hasn't unexpectedly turned head down at the last minute.
Good point. So when comparing the outcomes planned vaginal versus planned C-section for a term breech baby, what does this source material highlight?
It states quite clearly that planned cesarean section reduces the risk of perinatal death and serious short-term neonatal problems, morbidity, compared to attempting a planned vaginal breech birth.
Okay, so that's a significant benefit for the baby related to that specific birth event. What's the flip side? What about risks for the mother?
The notes indicate that the risk of maternal complications is higher with the planned C-section compared to a planned vaginal delivery in that particular pregnancy, things like infection, bleeding, etc. However, they also state there's no clear evidence of an increased long-term risk to the mother's health, although the effect of having a C-section scar on future pregnancies is noted as uncertain.
So it sounds like potentially a balancing act. You reduce the immediate risk for the baby with the C-section, but accept a higher immediate risk for the mother in that pregnancy, plus some uncertainty for the future. This seems to get right to the heart of that ongoing debate mentioned earlier.
It really does, yeah. It encapsulates the dilemma. And if a vaginal breech delivery is the chosen path, or perhaps happens unexpectedly, The notes point out that it requires significant skill and experience from the attendant clinician. And they note this specific skill set might be decreasing in developed countries because fewer vaginal breech births are actually being done.
That's a really important practical point. So if a vaginal breech delivery is planned, what are some key considerations mentioned in the notes?
Okay, so the notes mention that induction of labor might be considered, but only with fully informed consent. Continuous electronic fetal monitoring during the labor is recommended. And regarding pain relief, an epidural anesthetic may be used, but interestingly, it's not routinely advised for vaginal breech delivery according to this source material.
Not routinely advised. Interesting. What about the mother's position for the actual birth?
The notes suggest the lithotomy position, legs up in stirrups, and then the actual technique used during the birth is absolutely critical.
Okay, can you lay out the key steps and principles for the vaginal breech delivery technique as described in the notes?
Right. A really paramount principle that's highlighted is to avoid traction. That means absolutely no pulling on the baby until there's complete descent of the breech down to the perineum and the cervix is fully dilated. Patience is crucial here. Let gravity and the contractions do the work initially.
Right. Hands off, basically, until things are ready. Resist the urge to pull. What happens then?
So once you've got that full descent and dilation, the delivery involves controlled sequential steps. First the legs, then the scapulae, the shoulders and arms, and finally the aftercoming head.
The aftercoming head. That sounds like the trickiest part. Are there specific methods or tools mentioned for delivering the head safely?
Yes, the notes actually name specific maneuvers used for delivering the aftercoming head. These include the Morisot-Smellieveit maneuver, the Burns-Marshall method, and sometimes the use of special forceps, like Piper forceps.
Okay, specific names there, good for revision. And there's a really vital point mentioned about protecting the baby's neck.
Absolutely critical. The notes really stress the importance of avoiding hyperextension of the baby's cervical spine during the birth. That can cause serious injury.
Right.
And they also mention what to do if there's significant difficulty delivering that aftercoming head. Management options could include, in rare circumstances, synphysiotomy, which is surgically widening the pelvis, or more likely, moving rapidly to an emergency cesarean section.
Okay, that covers the whole management process really thoroughly, from trying ECV right through to the detailed techniques for a vaginal breech delivery if it happens.
Yeah, and if you connect it back, you can really see how complex the decision-making is. It needs careful assessment of the individual situation, really weighing up those risks and benefits we talked about, and making sure the right skilled care is available.
Definitely. So, stepping back again, what does the source say about the overall prognosis, the expected outcome for a baby-born breech?
Well, the prognosis, as you might guess, really depends heavily on the factors we've already discussed. The specific type of breech presentation, the gestational age at birth, whether the baby is preterm or term, and crucially, the mode of delivery chosen or that occurs.
And going back to that initial point about increased risk, how much higher is it?
The notes quantify it. They state the perinatal mortality risk death around the time of birth is increased by a factor of 2 to 4 with a breech presentation compared to a normal vertex presentation.
2 to 4 times higher. Wow. That statistic really underlines why it's managed so carefully.
It does. And the main reasons cited in the notes for this increased mortality are often linked back to those underlying issues we touched on earlier. Congenital malformations being more common in babies who present breech, prematurity itself, as breech is more common in preterm labors, and sadly, sometimes intrauterine fetal demise before labor even starts.
Okay. Is there any specific long-term follow-up recommended, particularly for breech babies, according to these notes?
Yes, there is one specific thing mentioned. The notes highlight an increased risk of developmental dysplasia of the hip, or DDH, in babies who are breech. Because of this, they recommend a hip ultrasound scan after birth specifically to screen for DDH. That's an important long-term follow-up point to remember.
Interesting, yeah. How the position in the womb can have that later impact.
Yeah.
Okay, finally then, what about the potential complications? What could go wrong during labor and delivery with a breech presentation for either the mother or the baby?
The notes list several potential complications to be aware of. For the baby, these include things like fetal head entrapment, where the body delivers but the head gets stuck in the pelvis. Oh dear.
Cord prolapse, where the umbilical cord comes down before the baby, which is a real emergency. And the notes highlight this as more likely with footling or complete breech types compared to frank breech.
Okay.
Also, various birth injuries during the delivery process itself, and potential neonatal issues needing support immediately after birth.
And for the mother, are there specific risks listed for her?
Yes, risks for the mother mentioned include prolonged labor, perhaps because the breech isn't as effective at dilating the cervix as a head is, or issues with pushing. Also, premature rupture of membranes and premature labor itself. Breech presentation can sometimes be associated with labor starting early.
Okay. Any other complications noted in the material that we should cover?
Yes, a few additional points mentioned include risks like cervical spine injuries to the baby, particularly if that hyperextension happens during delivery. Also, delayed delivery leading to potential asphyxia for the baby if things get held up. And just generally other traumatic injuries and even fractures that could potentially occur during a difficult birth. That certainly rounds out the picture of potential challenges. It's clear that breech presentation carries definite risks that need careful identification and really skilled management.
Absolutely. And pulling all that information together, from the basic definition, how common it is, the risk factors, how you spot it, the importance of ultrasound, those complex management decisions around ECV and delivery modes, the prognosis, the need for DDH screening, and all those potential complications, hopefully gives you a really solid overview based entirely on your revision notes.
Yeah, the goal was definitely to convert that dense material into a structured, high-yield summary, hitting all those core aspects you need to know about breech presentation for your revision.
We've covered the 3 types, that shift in incidence from early pregnancy to term, the key maternal and fetal risk factors, the clinical signs to look for, the crucial role of ultrasound and specialist input, the detailed options for management, including ECV pros and cons and vaginal delivery technique points, that increased mortality risk figure, and the specific need for HIP screening afterwards.
We've really tried to do a proper deep dive into the information provided, aiming to make it clear and help it stick in your mind.
So maybe let's leave you with a final provocative thought, building on that management discussion, particularly that comparison between planned C-section and planned vaginal delivery outcomes. We heard the notes state planned C-section reduces the baby's immediate risk, but increases the mother's immediate risk with some future uncertainty.
Right.
When faced with that data, how do clinicians, and importantly, how do families, actually weigh those very real, sometimes competing risks? How do they navigate that incredibly difficult and personal decision about how their baby should be born?
It really does highlight the complexity, doesn't it? And the very human element that sits right at the heart of all these clinical guidelines and statistics. Well, thank you so much for sharing your source material with us for this deep dive. We really hope this session has been valuable for your revision.
And remember, you can find more resources for your revision over at PassTheMSRA.com.
And don't forget about the free materials that are available at freemsra.com.